So I'm Caroline Struthers. I'm a researcher with the UK Equator Centre, hosted by the Nuffield Department of Orthopaedics and Musculoskeletal Sciences. And the Equator Network is an international organisation dedicated to improving the design, conduct and reporting of health research. And I'm here to talk about a patient involvement project I led in July. My long-term aim is to develop a systematic way to enable patient groups to lead on the design of treatment trials. Demonstrating patient involvement is already a requirement when submitting a funding application by most funders, and rightly so. But there's little, if any, funding given up front to help researchers achieve this, even if they are willing and able. The involvement may therefore be quite limited, not reported well, or scrutinised by funding panels. So I think it's unlikely that many funded projects have patient involvement which had a significant or measurable impact on the direction the research takes. And I think many important decisions about trial design could be made up front by bringing a reasonably large and representative group of patients together to discuss and reach consensus. I also believe that this initial work could potentially be done independently of clinicians and statisticians. Trial specifications generated on patients' own terms and in their own language could then be translated and incorporated into scientific trial protocols by clinicians and trial methods experts. In March this year, I submitted a grant application to the NIHR for this fantastic idea. I think I did a good job of arguing for the need for a better way to involve patients earlier in the trial design process. And despite enthusiasm for the idea from an eminent trial methods researcher, Sean Treweek, a hero of mine, the application fell at the first hurdle. I decided not to throw in the towel. Just before the rejection, a colleague of mine told me about the small grants available to do community engagement projects. So I applied to use the money to pilot my idea with a real live patient group. I asked for support from my department's patient involvement group, which is called Open Arms. And I was indeed welcomed with open arms by the leads Louise Haley and rheumatologist Laura Coates. Laura and Louise had led on the James Lind Alliance Priority Setting Partnership for Psoriatic Arthritis. I had found my first community. The James Lind Alliance is supported by the NIHR and brings patients, carers and clinicians together to identify and prioritise unanswered questions or evidence uncertainties that they agree are most important. And then they produce a top 10 list. So through conversations about what I should do with my new community, I discovered Laura and colleagues had done a feasibility study to see that if it was possible to do a trial of an alternative treatment strategy for people with mild psoriatic arthritis. So this patient population are often treated with powerful arthritis drugs used for people with more severe disease. Laura and co thought it may be more effective, less harmful, and certainly cheaper to treat them in a different way. The plan was to recruit to the trial from an existing active observational cohort of people with a diagnosis of PSA. Despite input from patients and adjustments to the eligibility criteria to make it easier for more people to join, the POISE trial team only managed to recruit one participant. I was delighted that Laura said she would be happy to let me loose on her patient community and try and recruit a bunch of them to help redesign the trial from scratch. I came up with the idea of having build a trial workshops, as I thought it sounded catchy and fun and would attract the attention of those familiar with the Build-A-Bear workshops, which were a big thing when my kids were small. I created an expression of interest form and distributed it via Laura's contacts, PSA-related organisations and charities, and also via the National People in Research website. I offered a choice of in-person in Oxford or Zoom workshops to increase the number able to participate and I threw in a few incentives. And I was very pleased to recruit 26 participants. The workshop format involves small group and whole group discussion and feedback of ideas designed to draw on the unique insights and experience of people with psoriatic arthritis. And the main questions we wanted consensus on were who should be included in the trial, what treatments should be considered for testing, what the most important outcome was, how it could be measured in the most efficient and least invasive way. And we also wanted ideas on the best way to recruit people and how to recruit people from less well-represented communities to make sure the trial would include people who represented a true patient population. So now I'm very pleased to introduce Helen, who attended the in-person workshop in Oxford. And she kindly agreed to come along and talk about, spend a few minutes sharing her experience of the workshop, how she found out about it, why she wanted to take part, and what it was like, careful, and, and what she hopes will happen in the future. Thank you, Helen.
Thanks, Caroline. Good afternoon, everybody. So yeah, my name's Helen, and I guess I'm an expert patient. So I'm someone with psoriatic arthritis, and I've had it for about 25 years. So it affects my joints and my skin. So very helpfully, Caroline has given me these questions to try and answer. So I'll just tell you about my experience. So how did I find out about the Build a Trial workshop? So I'm a member of the sort of like a volunteer for Versus Arthritis, which is a charity that sort of advocates for arthritis research. And I review sort of funding applications and research proposals for them. I'm also a member of BritPAC, which is the British Association for Psoriatic Arthritis, council or committee, something. So I get lots of emails requesting my kind of like, involvement in lots of things, but I'm a busy person, so I'm very selective about what I get involved with. So I got an email about this workshop. I live in Oxford, so it was local, and I thought, oh, that sounds really interesting, to actually design a trial, because you hear about these things, you never really get involved. So I thought, right, I'll volunteer. So I emailed Caroline and got recruited. Why did I want to get involved? Well, I'm really interested in research, and I guess giving something back. So actually, I've obviously benefited from trials to develop medicine and healthcare research. So I really wanted to sort of like give something back and just have an input, really, to try and shape things for people who perhaps aren't diagnosed or aren't on the right medication, So really, I thought, well, it just sounds really interesting. I'll give it a go. What was the experience like? So I attended the in-person one-day workshop, which was in Oxford, and there was around 8 to 10 people, expert patients with PSA there, and it was very expertly facilitated by Caroline. So she led us through various workshops. We had sort of like, they introduced the material, and then we had little sessions. So we got into groups of sort of 2 or 3 patients and just sat around tables and explored the ideas. So they gave us all the materials. We sort of did sort of brainstorming, wrote ideas on post-it notes, discussed in our small groups, which was very friendly. And then they gathered that material. So it was really good. But also, I think most importantly, it's quite a rare disease. So I just don't know anybody else with this disease. So it was really nice to meet other people with the disease and like compare notes and like, kind of like be a bit of a peer network with each other and just compare experiences and talk about, oh, what are you on and how does that work and that sort of thing. So it was just really, really nice to meet other people, because you just don't get that experience. What do I hope the impact will be for you, the new trial and the Trialblazers project? Well, obviously, I don't think I will benefit from this trial because I'm already diagnosed and on medication. But I'm hoping that the people sort of that come after me that are perhaps struggling to get on the right medication, the right diagnosis, will benefit. And we could really give sort of like our feedback through a patient pathway. What would it be like as a patient on this trial? What would I want to see? What would I want to experience? And I'm hoping that we'll be involved in the future. So perhaps on a steering group or an advisory group way, receive updates, you know, even just emails, and have that option just to input, you know, throughout the project. So it was a really good experience. So thank you.
Thanks, Helen, that was great. Right, so apart from inviting Helen to share her experience today, I didn't ask for feedback on the workshops from the participants formally. However, at least half of the participants said something positive in emails after the event without prompting, many commenting that the experience had been very interesting. Some also expressed a wish to stay involved with the project, as Helen did, and were interested also in being part of some sort of online peer support group for people with PSA. I am currently writing up a short report of the workshops to share with the participants and to my co-facilitators, Louise and Laura. But there does seem emerging a consensus that the eligibility criteria should be much more inclusive. And there also seem to be consensus that the treatment to be tested should be something more complex and individually tailored, but, you know, to be confirmed. So I'm not able to objectively measure or evaluate the wider impact of this work yet. However, I do hope the impact will include a successful funding application for Laura and her colleagues to try again with her trial. And I also hope it will lead to a successful funding application for my Trialblazers project. I hope to be able to collaborate with the NIHR and the James Lind Alliance, because the NIHR have a standard rolling call for research studies addressing James Lind Alliance priorities. So there may be a potential to extend the scope of the priority setting partnerships to include builder trial workshops to design trials indicated by one or more of the top 10 research priorities. It may also be possible to publish the results of builder trial workshops and explicitly link them to this rolling call. And another possibility is that some builder trial workshops participants could be like co-opted onto a funded trial steering committee and to keep the trialists on the straight and narrow. So this, yes, I'm coming to an end, good. I'll now be concentrating on writing my funding application. And if I get the funding, the patient group I'm planning to work with is people with ME. So if you're a patient or carer or otherwise directly affected by ME, you can register your interest in taking part in a builder trial workshop. And you can also register if you're interested in co-design, co-production methods, or generally interested in involving patients and the public in research in general. And thank you.
My name is Joanna Crocker. I'm a researcher based at the Department for Primary Care Health Sciences, and I'm funded by the Oxford Biomedical Research Centre to do research focused on patient and public involvement engagement. And I'm delighted to be here to talk to you today about a project that we're evaluating. It's the Diversity in Research Group, which we'll talk about in a minute. This is Hamid Khan, who's a partner and participant in the project.
Hello, hi everyone. My name is Hamid Khan, as Joe has mentioned. I'm an ex-service user of mental health services, and I'm also had open heart surgery in July 2019. I'm also a carer for my mom who has complex mental health and physical health conditions. And I think that's really important for me to emphasize that we, public and patients, come from all walks of life with different conditions and different circumstances. So that's something that which is very important to put forward, but also we have different kind of way of life. So for example, my background is working in the voluntary community sector and then going and teaching in further education college, and somebody else might be from a different background. So just be mindful that patients and public are patients and public, but also may come from different backgrounds that could really have a big impact on your research projects. Thank you.
Thank you. So the Diversity in Research Group was set up in 2021 by the Oxford and Oxford Health Biomedical Research Centres in order to increase the inclusion of public contributors in research, especially those from underrepresented or traditionally non-engaged groups. The group now has 15 members from within and outside Oxfordshire and has organised and taken part in a wide range of activities. For example, this photo that you can see was taken at a workshop bringing together researchers across the Medical Sciences Division with diversity and research group members at the old fire station in Oxford. I'm now leading a project in collaboration with group members and funded by the Oxford Biomedical Research Centre to form a detailed understanding of the impact of the group and how this can be optimised for the benefit of all. Hamid.
So I'm going to talk about why is this very important to me. And I think one of the reasons why it's important for me is that in research, we tend to get the same people over and over again. And I think it's really important that we start to think outside the box. And what I mean by that is, what about those who are not engaging? And when we think about people not engaging, we assume it's those who are marginalized and underrepresented. And it's not always the case. There's a lot of people out there who are very affluent, very articulate, but still not engaging. So I use the term non-traditionally engaged groups. So I got involved. What's important for me is how can we make it as diverse as possible so we get more and more impact in research that really benefits the public. And the public is diverse. So if the public is diverse, then it's a no-brainer not to engage with people from a diverse background. So later on, I'm going to be focusing on 3 parts, which will be in removing barriers, inclusivity, and valuing people.
Thank you. So this project is a participatory evaluation of the diversity in research group, co-designed with members of the group, coordinators of the group and researchers, and I'm really pleased to see a few members in the audience today. Thank you for coming. We are using ethnographic methods, including observation of meetings and events, interviews with diversity and research group members and those who work or could work with them, and analysis of documents. And we're currently interviewing group members and actively recruiting researchers to take part in the project. Through this evaluation, we are capturing impacts of the diversity in research group on health-related research and on people, including the public and patient group members and professionals, and impacts include both positive and negative impacts, and both anticipated and unanticipated impacts. And we're also looking at the actual impacts we can see, as well as potential impacts that the group could have or that we anticipate they could have. An emerging frequently cited impact on health research is changing the language of research information communicated to patients. And here is one example from a group member that I'll talk to you about now, who was involved in a clinical trial and drew on her experience as a woman with trans friends, children who are challenging gender identities, and membership of various online communities where such things are discussed. She said, quote, "For ages, I've been sending feedback to researchers saying, do not use phrases like individual of childbearing potential, which used to be in lots of these documents over and over again. Individuals of childbearing potential must take a urine pregnancy test." And the researchers would tie themselves in knots because they were trying to cover all possibilities of trans men, trans women, lesbians, celibates, all of these things. And it ended up with just ridiculously complex stuff, when all you actually need to say is, if you could be pregnant, you need to take a pregnancy test. And that's now in the document. That's what it says, and that delights me. A common example of a negative impact on patient and public group members, and they were largely very positive about their experience of involvement, but just to give you a different take on this, is frustration at the lack of feedback from some researchers after giving input, which was linked to their desire and motivation to make a difference to research. For example, one group member said of their involvement in a project, quote, "I can't say I have been in the loop on where that research has gone, and it's definitely frustrating for me. People might not have an incentive to be involved in research because, let's be honest, I don't get involved in research because of the financial aspect. It's not like it's a huge amount of money. You know, the goal is that the work you're doing is valuable, and it's really hard if you don't know what's happened with that further down the line. And so it would be amazing if we could get more input from researchers, you know, years down the line to say what happened to the research." As part of the impact on people, we are capturing what researchers may learn from working with the diversity in research group, whether or not that results in immediate changes to the research itself. For example, during a face-to-face meeting of a university professor with the diversity in research group, One group member, Della, produced a campaign leaflet published by a large UK health research funder entitled Be Part of Research, aimed at encouraging patients to take part in research. Della pointed out that all of the patients pictured in the leaflet appeared to be white, and drawing on her own experience as a Black woman, spoke of the negative effect this can have on Black and minority ethnic people who may consequently think research is not relevant to them. In the same meeting, other group members spoke of the importance of cultural competence when taking photos of people with different skin tones. For example, ensuring that the light is good for everyone so that people of colour do not appear as, quote, a black blob, which can then put others off getting involved. Although these discussions were not directly related to the questions the professor asked of the group, when interviewed 2 months later for this project, the professor cited these learnings as standing out in his memory of the meeting because he hadn't thought of the lighting issue before. In addition to capturing and explaining impacts, we are seeking to understand the potential barriers and facilitators to the identified impacts and lessons learned about what works, what doesn't work, and why. Hamid is now going to talk about some of the barriers and facilitators to impact from his perspective, which is also included in the project.
So thank you. I'm going to say as it is from a patient and public perspective. So it might not be politically correct, but I'm here not to politically offend anyone. And also it's not going to be very academic or professional, but I'll say as it is to keep it authentic. I think in any research project that you just start, you must first of all check in and tune in with your values. Because I think values is what's going to drive true, meaningful, authentic, inclusive research. So it's because sometimes we think we've got our values and that's it. We can now shove them away and we know what the values are. But actually values change with time because society changes. What was acceptable in the 60s was not acceptable in the 80s, and what was acceptable in 90s is not acceptable today because we've had legislation, for example, for around Sexual Orientation Act, we've had for people with gender reassignments. So obviously we've become more and more aware that we need to respect and value our citizens. So it starts with valuing people, is to ensure from the onset is how are we going to value people we're going to involve in research. And I think even though we moved leaps and bounds, there still happens as bad practice where they think, let's bring people in, give them a biscuit and a cup of tea, and aren't we doing a great job that we've got them around the table with us? That has to change. And yet they're making the most contribution in innovative thinking. So that's our first one. Second thing is about removing barriers. I think reducing, I'm going to use the word reducing because I think it'll be very, very unfair to expect everyone to remove every single barrier out there. But what I like to see is researchers striving to remove as many barriers as possible as they can for people to get involved. I'm a carer for my mom, and I only think that people who are carers need carer support. But then I'm not a parent, so sometimes I forget that people with children need child carers. But one of my best examples was where somebody had a dog and they wanted to come to an event and get involved, but sadly couldn't because they didn't have no one to leave the dog with, and the accommodation and the venue did not permit animals. So they wanted help with dog kennel fee. Now, it's very easy for us to have a laugh and a joke about that, but that is like for them a family member. So to remove a barrier for that person would be to honor their financial circumstances, providing support with the dog kennel fee. And they did get around it, but it just shows that we have to be very innovative in how we think around what are people's responsibilities. Then I want to go on to inclusiveness. And I think this is something really important. For example, if you're trying to work with Black, Asian, minority ethnic communities, and I'm going to focus particularly on South Asian community, because it'd be unfair if I said I'm expert in all the communities. But let's just focus, for example, for now on Pakistani community, which community I belong to. Now, for us, hot food is a way of welcoming people. It's not that we're hungry. It's not that we haven't been fed. It's just part of the culture where you show someone you made the effort to welcome them. Whether that's even when I get guests come to my house, I can put 100 snacks out and it wouldn't mean anything. But if I go and fry something or make something and put that, it's almost like I made the effort for the guest. So what I would say is that always be mindful that if you're putting on an event and you're looking at diversity and engaging with South Asian community, is they're not interested in posh venues. You know, sometimes they probably won't even ask you for travel expenses. But if there's hot food on, they're going to walk away thinking they were valued, they were welcomed, they were made to feel included. So it's about ensuring that we know what works for which community. For some communities, posh venue is very important, or accessibility, as in, like, the easiness of going somewhere. For some people, they like, if they're digital, they like online because they feel it's much more comfortable than going to in person. But for a certain communities, it might be, so every community you work with, you need to check out what would it be. And I want to keep it short because I know I've got less time, so I'm going to wrap it up. One other example I have is in Manchester, we had an event, and it was also inviting Jewish community, which is a community that lives in Manchester. And they provided lunch, and yet didn't think that the Jewish community have kosher, and they don't eat food that's not kosher. So when they arrived, these people, 6, 7 of them, couldn't eat anything because the food wasn't kosher. And if there was food kosher, you can't touch the plates have touched non-kosher food. So there's a lot of different rituals. And they all made a hoo-ha, but it was very simple. Either you could have contacted a local kosher provider, caterer, and got something in, or you could have contacted those people and say, we're very sorry, in this circumstances, we can't provide kosher food. However, you all got a £10 allowance. Please bring your lunch and we'll reimburse you. That will make them feel like they're valued. If they choose to claim it or not, that's their choice. If they choose to bring lunch or not, that's their choice, but at least they know you thought of them. But to arrive and then say, oh, sorry, could you not eat this or could you not eat that, and embarrass them. So that's what I want to finish, is that whenever you work with all the communities, start with creating Mr. Blog, who faces every barrier that you could think of, and you're going to get it right for most people. Thank you.
Thank you very much. So ultimately, we are aiming to produce recommendations for the Diversity in Research Group, the Biomedical Research Centres, and other research-related organisations seeking to increase equality, diversity and inclusion in patient and public involvement. And we're also planning to create infographics for members of the public. This is one of the Diversity and Research Group requests, so that they can showcase how they make a difference to research and therefore inspire others to get involved as well. And infographics for researchers, highlighting tips for involving people from diverse backgrounds. So please watch this space. And thank you so much for listening. A huge thank you to our Diversity and Research Group partners and participants, the Oxford Biomedical Research Centre, and our research partners as well for their support and input. And please do get in touch if you'd like any further information. My and Hamid's email addresses are on the back of the session programme. Thank you.
Thank you. Thank you so much for listening.
In the second part of the session, we're going to be thinking about public and community engagement in the context of global health research. So we've heard a lot of fascinating work that's happening here in the UK. Everyone in this group for the second half, we are all working in or with communities, not in the UK, but also communities in the UK. So I will introduce us all. This is Dr. Shobi Nagraj, and this is Professor Sassi Molyneux, and this is Dr. Alan Davies. And I think you've got everybody's biogs, so I won't go through them all, but you will hear more about their work. And I'm Catherine Rose, and I'm based in the Oxford University Clinical Research Unit in Vietnam. And I think we're ready to go. So before we launch into hearing about each of our work, we just wanted to really quickly consider what public and community engagement is in the context of global research. We don't tend to talk about PPI or PPIE. We talk about public and community engagement. That's semantics. It's a diverse set of activities across many contexts, and it's aimed at building mutual understanding and respect between communities and publics and researchers. And this match just shows the areas that we're either involved with research in or with. Many communities, definitions might be based on geography, special interests or goals, shared situations or experiences, and community membership may be choice-based or linked to characteristics. And there are many forms of engagement, so you'll hear a bit more about that. Variety of settings, variety of content, and the level and depth of engagement that may vary as well. And there we go. it is shareable. So we can think of a spectrum of engagement, from wide engagement that might be greater outreach, reaching more people, less participatory, tending towards raising public awareness. I'm missing a bit on this slide, but deep and narrow engagement. That's the sort of thing we've been hearing about so far. It's more involved, more participatory, and it takes more resource, and you're working with fewer people. And this is just to really show the range and depths and types of engagement here. All about building relationships, even partnerships, but equity. There are lots of issues around equity in global health research that may be similar to some of the issues here. They may also be different. So I work, as I mentioned, in public and community engagement at the Oxford University Clinical Research Unit in Vietnam. We have 4 sites. We are part of the Nuffield Department of Medicine. This is our Ho Chi Minh City site. Here's a few key stats that you can't read, so that's not very helpful, but we've also got sites in Kathmandu, in Hanoi, and in Jakarta in Indonesia. And there are around 500 people working in this unit, and they're all associated with Oxford. So just to give you a sense of what's happening outside of this city. I'm going to play you, and I hope this works, a short video, hearing about some participants in research. If it doesn't play, I'll send you the link. Yes, please. So this is a project catchily named Community-Based Participatory Research to Improve Dialogues with Underserved Communities at Risk of Hepatitis C. But the idea is, how do we involve people who have experienced this disease or are at risk of this disease in helping us to do better research?
Viêm gan C là một căn bệnh nguy hiểm, thầm lặng và chữa trị rất tốn kém. Lăn lộn giữa cuộc sống mưu sinh, rất nhiều người dân Việt Nam không hề biết mình mắc bệnh viêm gan C, đặc biệt là nhóm những người tiêm chích ma túy, sống chung với HIV, nhóm người có thu nhập thấp, công việc không ổn định, và nhóm nam quan hệ tình dục đồng giới chuyển giới MSM-TG. Và dù có biết, cũng rất khó có thể tiếp cận vì chi phí điều trị quá cao. Gánh nặng cơm áo gạo tiền khiến nhiều người đành buông xuôi số phận. Dự án tăng cường năng lực cộng đồng nhằm ứng phó với bệnh viêm gan đã tạo cơ hội để cho những tổ chức dựa vào cộng đồng thể hiện vai trò tự nghiên cứu, thúc đẩy kết nối, hỗ trợ chăm sóc và đã mở ra cánh cửa cho những người thuộc nhóm yếu thế tại thành phố Hồ Chí Minh cơ hội điều trị khỏi bệnh viêm gan C, sống khỏe và hy vọng về một ngày mai hạnh phúc. Khi bệnh tật được đẩy lùi, nụ cười lại nở trên môi nhờ tình yêu thương của cộng đồng và dự án tăng cường năng lực cộng đồng nhằm ứng phó với bệnh viêm gan.
So that one, it tells a powerful story of the human side of medical research, and it's a testimony to the potential impact on participants and the research of this kind of involvement. I'm sorry the subtitles were so small. We can make the link available so you can watch it yourselves. But it's important to say that was scripted and co-produced by project participants with support from the research team. So now I'm going to hand over to Alan.
Hi. So I work with a group called the Global Health Network, leading their online hub called MESH, which is a resource hub for community engagement. But up until 2020, I was based in Kenya, working with the KEMRI-Wellcome research program. So the KEMRI-Wellcome research program is a really large biomedical research institution with about 1,000 staff and a whole wide range of multidisciplinary research, from clinical trials to health systems research to social science. It also, to support that research, has a wide community engagement strategy, which involves a whole range of activities like community advisory boards and open days, and many other activities. Part of that engagement strategy involves engaging school children, and over 10 years, it's built quite a large school engagement program, which is aimed at promoting awareness of locally conducted research among students, raising interest in science, positive attitudes towards science and science careers, and really importantly, raising researchers' awareness of students' views about research towards incorporating some of their views into the way in which research is being run. And that's done through a range of activities, which includes science clubs, competitions, lab tours, attachment scheme, online engagement, and a young person's advisory group, which is really similar to PPI groups in the UK, but targeted towards capturing young people's views on research which involves them, really. So that's the school engagement program. In Kenya, I'll talk about the evaluation of that program later.
Hello everybody, my name's Shobi and I'm a clinical researcher in the Health Systems Collaborative Group, which is in the Centre for Global Health Research. And I'm just going to say a little bit about some work we've been doing locally. What happened during the pandemic is that usually I'm overseas in some village in rural India, but I couldn't travel during the pandemic and I was here in the UK and actually started to see that some of the challenges that we face overseas in very rural areas we were seeing here in Oxfordshire. So for a lot of people who might not know, there's an 11-year life expectancy difference in male life expectancy between some of the more affluent areas of Oxford City and some of the 4-mile radius away from here. And there were children not being able to actually have meals, hot meals every day, and there are families really struggling due to the cost of living crisis. And so for the first time in a long time, the Marmot Review came out and showed that in over a century, life expectancy in the UK had actually started to level off and decline for women living in poverty. And so we decided to bring together a group. So I didn't really know I was doing community engagement at the time, but we brought together a group at Green Templeton College, and we called it Addressing Child Food Poverty from Grassroots to Policy Actions. And we brought together all the grassroots groups working across Oxfordshire. 2 academics agreed to come along, policy makers and schools and housing associations. And we actually brought everyone together at the same table and they heard these really powerful narratives from the ground. And it started off a partnership with community groups together with the university. So we've developed academic partnerships, but also with policymakers. So we've actually got some policy actions from this. And so since November 2021, when we first started this, we've now fed into, excuse the pun, fed into the food strategy for Oxfordshire. We've had a scrutiny review of child poverty in Oxford City. I worked together with the OUCRU Food Crew, which is a group of 9 organisations in the OUCRU postcode who work with very hard to reach groups within Oxfordshire, and we've done theory of change workshops, so they were able to actually start off their own research processes, apply for funding through the National Lottery, and that's us celebrating our £300,000 win from the National Lottery, which has kept food groups going for a few more years. And then we held another roundtable earlier this year to follow on from that work, and we've put together some policy recommendations which we hope to take forward to encourage the uptake of what we call Healthy Start vouchers for preschool children here in Oxfordshire, to actually improve school meals in terms of nutrition and universal access to school meals in Oxfordshire, and also create healthy food environments. So working in real multi-stakeholder engagement across the county council, city council, the university, the hospital, and housing associations as well. Thank you.
Thanks, Shobi. So this whole session was built about builders looking at the benefits and impacts of working in this way. And we've heard quite a lot of the benefits in the first half. And now we're going to talk a little bit about what we're doing to try and work out what the benefits and value is in our area of research. And just to preface that with why and how to evaluate public and community engagement. We've all had conversations with clinical researchers who say, well, it's all about numbers, and beyond the numbers, it's just really hard to measure. And we want to try and work out how to tell that story. And that telling that story will help people, it will motivate them, it will motivate participants, and it will motivate researchers. So why evaluate? Are we achieving what we want to achieve? And what about other stakeholders' goals? There are different types of evaluation. It's a spectrum from light touch to in-depth. And what you do is going to depend on the resources you have. Also what you want to try and find out. There's formative evaluation, which I will talk about in a minute. Process evaluation, looking at is what you're doing working? Is the delivery of it working? Did you achieve what you wanted? And impact evaluation, what's changed? And how can we capture that change? And also project evaluation versus program evaluation. It's one thing to evaluate a discrete project, but actually working out what's happening at a program level. Alan talked about the schools program. Alan's going to talk about evaluating that program. And I'm interested in looking at our engagement program overall and seeing what difference that makes to the whole research piece at OUCRU. So key message, we'll just drop this in now. Keep it proportionate to activity funding and needs, and select from a toolbox. And hopefully you'll have some more ideas after hearing about what we've been doing. But in terms of the value of engagement to OUCRU's research, I have been working on some formative research over the last few months with 3 other colleagues and an awful lot of researchers who have agreed to participate, and many of them said, wow, the tables are turned. Now I'm a research study participant. So that in itself is interesting. Our objective was to gather data to inform what measures or success indicators there might be for this programme, developing a framework and training tools, and what do we need to do to strengthen our internal processes. And I should perhaps add a little bit more about OUCRU. Research covers malaria, typhoid, tuberculosis, dengue, drug resistance infections, clinical trials, community-based studies, a wide spectrum of research. And the engagement programme was established in 2010, and it works with research participants and stakeholder communities. So we're really at a good stage to start to take this bigger picture view. And I meant to add, after the film, there was a little photo next to it, but the film was actually premiered at a policy meeting where there were all sorts of policymakers from different levels, including the governmental level in Vietnam, and participants who made the film were present at that premiere as well. So that's one example of impact, but we really need to do more to be able to capture those stories. So our research preliminary findings, we decided to talk to researchers to understand what their views were. That's our starting point. That's obviously not the ending point. There are other people's views that matter in this as well, particularly participants who are outside of the research community. But our research has told us engagement they regard it as a legitimate and even integral part of research, but definitions vary. There's regular engagement, but its relevance depends on type of research. So if you're doing lab-based research, there may be less of a need or a drive. You might have a strong personal interest to communicate that, but that's very different from if you're doing a large clinical trial where there's a huge amount of interface with people outside of the research and the sort of scientific academic community. Researchers don't always feel sure of methods available or feel confident in applying them. They'd like to do more, and they're motivated, and they have a clear sense it would directly benefit the research. And some mention participants, so we can do more about telling that story. They articulated personal, institutional, and structural barriers to doing engagement. So I'm really interested in what you've all been doing here in Oxford. The 4 key themes, this has got way too many words on it. But just 4 themes. We grouped it into our findings. We haven't done the full analysis yet, but general views and personal experience of engagement, knowledge, skills and confidence, enablers, opportunities for development and challenges. I just wanted to highlight a few points because, I mean, you can't really read that. Definitions varied, attitudes were positive, but it did depend on the type of research. And researchers who are really motivated might go above and beyond just because they're passionate in talking about their research, but they might just want to stay in their lab, and that's okay. But if you're doing a clinical trial and you're not recruiting, which interestingly, retention is less of an issue for us, but recruitment, there can be a lot of issues around recruitment. If you're using engagement as a sticking plaster, what can we do about that? So you're actually thinking about the engagement and the methods beforehand. Motivations vary from what we call the ethical, it's the right thing to do, to the instrumental, it's going to help you get your research done. But lots of researchers feel both are important. Planning for engagement at research design stage, we've heard a lot about that, and also another session this morning was talking about that. More recognition within the institution for researchers. But the evidence of impact would also motivate researchers. The pressures, there are a lot of pressures currently inherent in the grant funding and ethics approval ecosystem. So that's a bit of a garbly technical phrase, but basically it's not always easy to do good, meaningful engagement because writing grants takes a lot of work. They have to go through a lot of people. The timeframes can be short, the calls can be short. And then when you design your study, you then design your protocol, revising your protocol, doing that in Vietnam. I've never been involved with that, but the researchers I've spoken to say, we've done it once, there's no way we can do it again. And the ethics committee really it was frightening the horses, some of these ideas, so we have to tread carefully. And these are really practical things. And several researchers express this as a paradox. I know it would help my research, but if I do anything, it's seen as an add-on, which I have to make happen on the side or in my own time. So enablers, case studies of engagement methods and models as relevant to particular types and stages of research would help. And what else would help? And scope for developing our practice around community advisory boards, engagement for recruitment and retention in trials. So it's not reactive. So I've learned a lot today and I'm very glad to have made these connections. Next steps, I'll whiz through this. We've got to do our full data analysis, and our provisional recommendations are around enhancing our researcher engagement and support, developing our evaluation approach. So that's the evaluation framework, which is looking at how we go from project evaluation to program evaluation, and further research. What can we do to understand how best to support participants at the recruitment stage? And I'm really interested in conversations that are going to come of this session and this whole event with Wellcome funded Oxford overseas units, the Oxford engagement team, the NIHR PPIE team, and also at OUCRU. We've got a new initiative, a collaborative initiative called the Good Trials Prism, looking at strengthening clinical trials in global health context. But there are 2 strands around that are really around the sort of participant being responsive and being ethical in how you are working with participants. Alan, over to you for a programme evaluation perspective.
Thanks. I'm going to whip through this quite quickly so I can go to the video because it's a bit more interesting than me really. But we for this school engagement program, we used a mixed method approach. We measured impact through a set of pre and post surveys, student surveys, to measure things like impact on student attitudes towards science, awareness of careers, and that kind of thing. We had discussions with researchers about the influence of engagement on their kind of work, but also really importantly documented the changes that happened to engagement or to research as a result of that engagement. And what did we do with those insights once we had them from students? And the third component was we thought it'd be really great to have a component of the evaluation that would give the perspectives or the experiences of engagement from the perspectives of the students. So what we did was we handed the camera over to groups of students and asked them to make films about their experiences to share to different audiences. And that revealed quite a lot to us. The process revealed a lot about the engagement, some of the problems that engagement brought about, also some of the benefits. Can you whip back to that?
Hi. Yeah, so it's been nice to hear about some examples of evaluation of engagement for individual studies and also for whole programs of work. And I was involved in helping to design and to evaluate the community engagement program as a whole in the KEMRI-Wellcome program in Kenya. And one thing that we developed an interest in from the work in Kenya, but also in other countries, was really trying to work out what's working for whom in what way with all of these activities. And to do that, we wanted to conduct a realist review. And we decided to focus that on large research programs that are conducting malaria research. And I just wanted to outline a little bit more why we thought a realist review is important. I think what we've had really nicely illustrated through this afternoon already is that there's a huge variability in public involvement, public engagement, community engagement, in the language, in the concepts, in what people are trying to achieve when they're talking about engagement, around guidance of what's needed, how's it best done in practice. And what often happens in practice is that there's an emphasis on the activities and on the interventions, as opposed to the relationships and the goals that are trying to be achieved behind those activities. So you often hear about, in our international settings, a community advisory board which does activity this and that, or a radio program that's covered this and that topic. But what's it achieved in what way through those activities? And because these are often multi-stakeholder, complex social interactions that are happening as part of engagement, it's really important to understand the relationships, the context, the culture when doing these evaluations. And so we realized that we needed to look at the literature to learn more about what everybody's written to work out how engagement works. And looking at the literature and pulling in theory, what we developed, and we'd be really interested to hear your thoughts as well, what we developed was a sense that what's often happening is the building up of working relationships between community members and researchers or research staff. And these working relationships are constructed through, in this diagram, the coloured circles, through the negotiation and exchange of benefits, through a sense of influence for stakeholders. They have to feel like what they're talking about is responded to, and researchers being present, being familiar and becoming familiar to different community members. And if and how this actually works in practice is very much shaped by the culture of a research institution or those who are running these engagement activities. And in global health research, it's very much shaped by how global health works more generally. And so what we can see is that there can be a double-edged nature to how this community engagement works. It can challenge some of the inequities that are there in global health research, or it can help to reinstate and reinforce those inequities and power dynamics if we're not careful. And so some of the recommendations and ideas that came out of this as policy briefs and as an animation are available online, should you be interested to hear more. Over to you.
Cool. And I was just going to say a bit more after what Sassy has just said as well about how we might also consider social value when we're talking about engagement. And one of the things that we've done locally is started to develop an evaluative framework around social value. So that's the value that people give to the experiences from the interactions or the interventions that they're experiencing. And there's something called the social return on investment scale, which I'm just learning about myself, but looking at return on investment in terms of financial inputs and what we get out of programs, but also thinking about what things mean to people on the ground. So for example, we work with Oxford Mutual Aid and we did an exercise where we thought about what does a food parcel actually mean to people, and it was actually much more than just the food. It was a sense of somebody caring about other people, a sense of actual coming out of loneliness, building trust, not feeling judged at all for actually requesting food. And actually the volunteers that worked for Mutual Aid also got a mutual benefit from it as well. So using things as Sassy's described about the mutual benefits for both partners and what it means to them, and how we can actually measure and start capturing some of that social value, maybe through participatory videos as well. Thank you.